G'day, I'm Elliot. I'm going to be covering the Epistaxis segment of the PPHC OSCE. So we've been sent to Zach. He's a 24-year-old who's experiencing a nosebleed or an epistaxis. It's been described as sort of dripping in nature, and the onset was after a digital injury, so picking his nose. He's got a history of recurrent nosebleeds from digital injury, but there's a couple other things we want to look for during our assessment, and that's sort of previous history of nasal or cranial surgery. We want to find out if he's on any anticoagulants. So in our primary and secondary survey, we found no abnormalities in terms of his vital signs. He's not on any medications. He hasn't got any allergies to any medications. At the moment, you want to try and gauge what level of epistaxis this is. So what I've instructed Zach to do is place firm pressure on the fleshy part of his nose, and we're going to hold that there for about 15 minutes to see if we're going to have any cessation there. If not, then we're going to move forward into some more treatment options. Another good idea is to get him to lean forward, and also with an emesis carton to spit out any blood, because we don't want him to swallow it, because it can make you feel quite nauseous and unwell. Okay, so Zach here has been compressing his nose for 15 minutes, so now we want to reassess. A huge aspect is we want to monitor for signs of hypovolemic shock. You can lose quite a lot of blood volume through your nose. And airway compromise, so again that's why you're encouraging to spit out any sort of bits of coagulated blood. You don't want anything getting trapped in the throat there. So Zach, could you just remove that from your nose please? Just keep leaning forward and remove it. Cool. So I'm still seeing a nice continuous drip, so with 15 minutes you can pop that back on please, thank you. We haven't had any cessation with direct pressure, so now we're going to escalate to that sort of from a mild to a moderate epistaxis, and we're going to use a pharmacological intervention. We're going to spray some iron adrenaline up his nose. To administer adrenaline, what we want to do is draw it up properly. So we're going to dilute adrenaline into 1/10,000 mix into a 10 ml syringe, and what we're wanting to do is administer 2 mils, which is 0.2 milligrams into each bleeding nostril. So for the case of Zach, we're just going to administer 2 mils into the one bleeding nostril. Okay, so what you want to do is check your adrenaline and also drug check it. So adrenaline 1 milligram and 1,000, expiry 0219, so get that to be drug checked. So I'm going to draw up 9 mils of saline, just normal sodium chloride. Then we're going to dilute the adrenaline. So here you're going to have 1 milligram of adrenaline in 10 mils. So I'll dispose of that there. Cool, give it a nice shake to mix it in. To administer, you can administer 2 mils out of a 10 mil, but I quite like to put it into a smaller syringe just for ease. So cool. So that's our adrenaline drawn up here. What we're going to do is attach it to a mucosal atomizing device and also prime the device as well. So if we pop this on the top, and then to prime, just push through a little bit until you see it there. So that's nice and primed, okay? Ready to go. So we have our intranasal adrenaline ready to go. So prior to giving it, what we want to do is just inform the patient what's going on. So Zach, I'm going to spray this up your nose. It can feel a bit strange. Sometimes people feel tickling down the back of their nose. But what this will do is hopefully close those vessels and stop that bleed. Before we take the pressure off, what I can get you to do is just to spit out any blood you have in your throat, and then right before we're going to blow your nose, so we want to clear any clots out of there, okay? When I push then I'll get you to sniff, but before, while we're getting everything ready, I want you to blow out, and then I'll put it in, and I'll go 3, 2, 1, sniff, and
okay, cool.
Got it. Right here, and then I'm going to get you to sniff. So 3, 2, 1, sniff. There we go, and then place the pressure back on there. So it can taste a bit funny, but we'll keep that pressure on there for another 15 minutes and reassess. So what the adrenaline does is the alpha-1 receptors, the adrenaline attaches to it and vasoconstricts small blood vessels. So what we're trying to do is just close any of those micro vessels that are open that are causing the bleed. Cool, so Zach, it's been 15 minutes since we sprayed that adrenaline up your nose. So what I'll get you to do is slowly take the towel off, and we'll just have a little reassess. Cool. So I see that the bleeding from Zach's nostrils stopped, which is great. The adrenaline's worked really well, so I'm really happy with that. Yeah, you? Mm-hmm. Cool. What I recommend, or firmly recommend you do, is go and see your GP. Because we have given adrenaline, that's just something we want to be really careful of, because it's obviously required a little bit of an intervention to make that blood stop. Mm-hmm. So go and see your GP. Because there's a few other things they may do. They may cauterize it, they could put a nasal tamponade if it starts again. If it started bleeding again, what we could do is we could give a second dose of that iron adrenaline. If it continued to bleed and started getting severe, you'd want to be calling for an R50 backup, and they could either put a nasal tamponade in if they have one, or an ET tube to try and stop that bleeding and transport to hospital. Zach, in terms of what you want to do for the next few hours, if you don't want to go to the doctor right now, is avoid like hot steamy showers. So anything really steamy will could get that blood flowing again. So like hot soups, tea, just avoid that. Avoid blowing your nose as long as you can, because you don't want to rupture any clots that may be stopping the bleed. You can lubricate some of your like the nasal passage with your Vaseline. Just put it in there. It creates a little bit of a barrier to stop any bleeding coming through, and just allows a bit of time for it to heal. But before we go, I just want to ask: do you have any questions at all? Do you have any concerns?
No, that's all right. I can organise the doctor visit and every single day.
Cool. So what we'll do is we'll leave you with a bit of paper that you can take along to the doctor so they can see everything we've done.
Hi, I'm Ryan Bigger. I'll be doing the headache section of the PPHC OSCE. So we're being called today to a 65-year-old male for a cheek complaint of headache. So he tells me he's got a bit of a headache, and there's 200 different types of pathologies that can lead up to a headache. It's really important to ascertain what's the reason he's having a headache today. So we just want to gather a bit of a history. So I've gained a brief history from the patient, so next I want to obtain a full set of vital signs. So a good tool to use in our setting for a safety net is the red flags, and this can rule in and rule out potential dangerous, life-threatening pathologies that could be causing this headache. So I'm just going to go through this checklist with you, okay? And it could be something we could both talk about, and as I go through it, then you can tell me how you're feeling, okay? Yep. So a headache or neck pain following neck manipulation. So if you're able to touch your neck to your chin, back and forth, have you got any neck stiffness or neck pain?
No, not neck, it's just still severe.
Okay. And this was this a sudden onset? You said it was gradual, wasn't it?
Yeah, it's gradual.
So you can rule that out. And he's afebrile, he's got a temperature of 37 degrees, so we can rule out potential infection. Have you been vomiting?
No, I haven't
No
been
vomiting?
no.
How about feeling of being nauseous?
No, not too nauseous.
Perfect. And next we're going to go down the focal neurological signs, so I can do a full cranial nerve test. Okay, so first of all I just want to check the olfactory nerve, just make sure your sense of smells are good. So can you close one nose, sniff and close another nose? Okay, no change.
Yeah.
For the oculomotor, tracheomotor and abducens nerves, these supply the nerves of the eye movement and in control of the eyelid and the size of the pupil. So I want you to open and close your eye. If I had a pupil torch, I'll assess the diameter, assess how reactive it is to light, and I'll get you to follow my finger as well. Also assessing for any nystagmus. That's perfect. We could also do a finger to nose test on top of that. Okay, so the trigeminal nerve, that supplies sensation to the face. So I'm just going to quick sensation, close your eyes and tell me if you feel this on both sides.
Mm-hmm.
Both sides?
Mm-hmm.
Both sides?
Mm-hmm.
Perfect. Now I want to test your facial nerve. So if you can just scrunch up your face for me. Make a facial expression, perfect. Now the vestibulocochlear nerve. So this is the sense of sound. So if I could get you to close your eyes, which side is this coming from?
Left. Right.
And the vagus nerve. So this is really kind of hard to measure, but if you could say ah, e, perfect. And accessory nerve. So I want you to poke your shoulders for me, perfect. And the hypoglossal nerve. So if you could poke your tongue out and put on each side of your mouth, perfect. How does all that feel? Does it feel normal?
Yeah.
So once we've ruled out any focal neurological signs, you can carry on through our red flags. So he's had no altered level of consciousness with me. He's been GCS 15 the whole time. He does seem quite discomfort. So we can rule that out. And have you knocked your head recently? Have you had a fall or anything that you can remember?
No.
Okay. And medication-wise, what medications are you on, if any?
I don't take any medication.
Nothing at all?
Yeah, been real good for my health.
Okay, you're quite healthy.
Mm.
Perfect, that's what I like to hear. And any signs of temporal arteritis? So he's complaining of right-sided headache at this stage, constant and throbbing feeling around his right temporal area. So I'm going to investigate that a bit further, just to rule in and rule out this pathology. So it's around this area, is it? Do you mind if I just touch it?
Yeah.
Okay. Let me know if it just gets a bit tender.
Yeah, they're
Getting more tender? Okay. And how's your vision out of that eye at this stage?
Yeah, the vision's alright at the moment. It's just kind of just a bit sore, kind of just moving around there, and just kind of fades out around.
Okay, so that's a red flag in my perspective. He does have signs of temporal arteritis, so I'll be keeping that in mind, and it's likely that we'll be going through to hospital just because of this. And you're a male, so there's no history of you having a baby, you haven't been pregnant, so we can rule that one out. And have you had a stroke in the past, or have you
had a stroke?
Traumatic brain injury of any type?
No, nothing like
brain
that.
injury? Okay,
That's pretty good.
so we've ruled that one out. And any family history of vascular abnormalities? So this means if someone's had a brain aneurysm or a stroke in the past in your family, have you had one of those?
I don't think so. I can't fully remember, to be honest.
Okay. And what were you doing at the time of this onset?
Nothing, just
Nothing?
normal day.
So no sexual activity or anything like that?
No, it was just normal, just been a normal day, walking down the mailbox.
Okay, perfect. So that he's ticked off one red flag at this stage. So Zach, you're in 6 out of 10 pain. You're looking quite discomfort. And have you taken anything for your pain?
Yeah, I've taken, I think, 2 of the paracetamol and 2 of the ibuprofen.
Okay. And
Yeah.
how long ago was that?
Yeah, 3 hours ago.
3 hours ago. Okay. And 6 out of 10 pain. It's
Yeah,
quite a lot of
still-
pain. Would you
yeah.
like me to give you something?
Yeah, I can't cope right now with it.
Okay. Do you have any allergies at all?
No.
Okay. So do you mind if I put a needle into you and
No, it's
give
okay.
you some morphine? Have you
Do
used morphine
what you
before?
want to do. Yeah, I've been walking in the
Okay.
hospital.
Okay. No allergic reactions or
No,
anything?
that was all good.
So Zach can obey my commands. He's talking to me quite well. So for pain treatment, I would be giving him, I'll be placing an IV into his arm and giving him a low dose of morphine just to see if this relieves any pain. And we can, as soon as we get to 4 hours, I can also top it out with some ibuprofen and paracetamol as well. Okay, now I'm going to draw up morphine. So first I want to check my drug. So I know it's got morphine, 10 milligrams in 1 ml, and expiry date is 2020. So I just want to quickly check that for oxider. So I've got my equipment here, so I want to draw up my saline first. So check that some date as well. So May 19, sodium chloride, 0.9%. So this is hemodynamically stable, obeying commands and no respiratory distress. I'm going to give him a smaller dose, so I might go for 3 milligrams, pushing slowly. Zach, if you start to feel sick or nauseous or anything like that, you're going to let me know?
Yep.
Perfect, and I'm going to recap. Put that in my pocket, note it down the time, and I'm going to give it a flush in a minute.